Hello.
Hello.
Huh? Am I audible?
Yeah, so we are live now.
Huh. Yes.
Good afternoon, everyone. I am Ada, your moderator for today's MedTalk Digital CME, powered by IGCP. It's my pleasure to welcome you all to this insightful session on focusing on a topic that lies at the heart of responsible pediatric care. Antimicrobial stewardship starts early. Pediatric prescribing in the new era. In an age where antibiotic resistance continues to rise globally, understanding and implementing proper antimicrobial practices right from early childhood is more important than ever. To take us through this important discussion, we are honored to have with us Professor Dr. Sunil Kumar Agarwala, sir. Let me share some of his achievements. He did MD and professor at the Department of Pediatrics Sardar Vallabhai Patel Postgraduate Institute of Pediatrics, Cuttack. Dr. Agarwala is a renowned academician and clinician deeply committed to advanced pediatric healthcare and guiding the next generation of doctors towards rational and evidence based antibiotic use. We are delighted to have him with us today. Now, let's warmly welcome Professor Dr. Sunil Kumar Agarwala, sir, to begin today's session. It's over to you, sir.
So thank you very much, Ada Afsin, for your nice introduction regarding me. Good afternoon, all doctors. I welcome you to this IJCP platform, which is a message giving and knowledge giving platform for doctors. I welcome all doctors on behalf of IJCP and on behalf of mine to logging in this academic platform. As you know, that in day and out, being a pediatrician, we are using many drugs, we are using many cough syrups, we are using many antibiotics in our management of many diseases in children. So the topic of discussion today is antimicrobial stewardship. It should start early so that pediatric prescribing in new era, that means how we are going to change our behavior. So there is a always tussle between pharma industry and between the doctor's prescription rational use of medicine. Now you must be knowing that from 3rd September till now, the Madhya Pradesh and Rajasthan has banned the usage of cough syrup below 5 years. And it has been seen in the two brand, one is Cold Reef and another is Relief. They contain very high amount of diethylene glycol, which is a contamination at the industrial level, and that has been wrongly instead of pharmaceutical or pharmacological solvent, the industrial solvent diethylene glycol has been used, and that has led to more than 23 deaths among around 5 year below children. So why it is happening? It is because of irrational use, or it is because of rational use of the drugs, or it is the lacunae of the DCGI, or it is a left and right writing of molecule where it is not indicated. It has been told that the cup syrup is not needed below 2 years. Whatever paracetamol can be given for the fever, and ambroxoprolene can be given for the cough, and antihistaminic can be given after 6 months if at all it is indicated. So we have to rationalize the use of medicine in the pediatric practice. So what are the 5 rights of rational medicine use? The right patient, the right drug, the right dose, and the right way, and the right route has to be given. Many a time, suppose we are writing drugs and syrups, I will tell you, less than 1 year, always preferable to write the drug because the quantum of the medicine will be low, and above 1 year, we will writing the syrup because the 5 ml or 2.5 ml or 7.5 ml, the dosing will be the better option. Why rational use is important? Because irrational use has various harms. Suppose you are using wrongly the high dose, it will cause more adverse event. If you are giving underdosing, then it will not work. Ineffective and unsafe treatment. Increased morbidity, that ADR, adverse drug events, can be a issue because many a times the paracetamol which is available either in a 125 ml or it is a 240 or 250 per 5 ml. If you wrongly give the higher dose, it may lead to gastritis and sometimes it can lead to hepatotoxic. So we must be knowing how much ml contains how much molecule of the pharmacological ingredient, and that's why the API molecule, which is the main molecule, which is the main component in the drug, which is given in a drug delivery system. Mostly the children, they used to take the molecule in a oral formulation, either in the drop or in the syrup or in a dry syrup or in a suspension form. So why rational use is important? Because distress, harm, and it will add to the cost to the patient. Sometimes the dry syrup, it is rated that after reconstitution it can be used within 7 days. But if you use that molecule beyond 7 days, the efficacy, the power of the ingredient is going to be declined. So promotion of appropriate and safe drugs in children is the need of our globally. Children are not supposed to be mini adults. So by looking at a 50-kilo man or woman, we cannot make it one fourth and give the doses for a small kid. So that's why please remember, children are not mini adult. They are supposed to be individual, and the proper dosing milligram per kg has to be given to them. Now you see, from the birth, preterm, newborn infants, then term, then infants, toddler, 1 to 3 years, then children, they are growing children, then adolescent age group till 18 years, it is in the domain of the pediatrics. Now starting from drops, then coming to the suspension or syrup, then around adolescent age group, we are giving in the tablet formulation. So it has to be acceptable. For an example, we are giving a tablet to a small kids, they cannot, because the taste part will be not good and it cannot be miscible or dispersible into the water or in solvent. So that's why we have to go for ready-made use or ready use suspension, or it is being mixable in a liquid formulation, then the delivery system will be good. So there are multiple guidelines coming to Indian Academy of Pediatric recommendation and guidelines for the usage of antibiotic in drugs, and pediatric TB management guideline, which has been very much uniformized into the use of AKT, anti-cox therapy, into the pan-India, that is NTEP, National Tuberculosis Elimination Program, India Newborn Action Plan, that is India Newborn Action Plan. So there are many molecules are there which can be given as a modality of management into the children. So now for last 2 years, 3 years, we are having IAP standard treatment guidelines. In 2022, it has to be used, and there are Indian Academy of Pediatrics guidelines for parents as well, because there are many guidelines which has been made into the parents, that how the parents should give molecule, what are the information to be given, and when to be giving, whether it is BD or OD, or it is after food or before food or at bedtime. So that information has to be given. So National Health Mission is coming as a big role in the drug delivery system in our country, and developing standard treatment guidelines. Why it is important? Target priority conditions based on local disease factors, coordinate with special program, use fewest drugs necessary. So it has been told, once the drug is not required, don't disperse the drug to the children. So choose cost-effective treatment. If the same molecule is given from one pharma industry 1 rupee and another is charging 10 rupees, so there is no point of giving that costly molecule by another pharma industry. And that's why Jana Sudhi Yojana in the PM budget, it has been targeted that the many ingredients, all the generic medicines can be used for day in day out practice. So a lot of debate is there whether to use generic or whether to use the good company molecule. So that has to be individually, it has to be prioritized. There are many protocols coined by AIMS and PGI protocols for the usage of this molecule in the neonatology. I mean, neonatal age group, almost all molecules to be given intravenous. There is no antibiotic given orally, has no role. So that's why IAP has come out with a rational antimicrobial practices in usage in children. I must tell you, the antimicrobial includes antibiotics, antiviral, and antifungal and antiparasitic agent. But whereas the antibiotic is a subset of that, which include the only antibiotic as well. So there are a lot of rational antibiotic therapy guidelines are being made by the IAP, and that has to be followed in our day-to-day practice. Many a times there is a pressure that newer drugs are almost always better drugs. It is not true, because few years back there were many companies they were came up with the pharopenem, but pharopenem is a molecule where the patient is getting imipenem group of antibiotic in IV setup in your HDU or in ICU setup. So once they are converted to oral formulation, then pharopenem can be used. But it is never to be used in left and right to a baby who is suffering from UTI or abdominal sepsis. So that's the reason if you are using injudicial use of this antimicrobials, that will lead to resistance. And as we all know, there are a lot of bacteria they are developing resistance because of transduction, because of plasmid transmitting material, and there are fungi nowadays are resistant to the Jolan group of antifungals. Then cancers, they are also resistant. Antimalarial, I mean, the chloroquine is almost resistant to almost both vivax and I can say about falciparum. There are many HIV drugs are not doing well. So all those resistance will occur if you are using injudicious use of antimicrobials. So that's the reason costly drugs are always better drugs. This line is not true. Brand name drugs are always better than generic drugs. Again, it is a $1 million question. So, but still, if the molecule is dependable from a good pharma industry, then definitely it has to be prescribed. So, polypharmacy is always better. That is not always true, but FDC are always superior. There are fixed dose combination or molecular there. Let's take the example of antiretroviral drugs. Let's take the example of leprosy drugs. Let's take the example of tuberculosis, anti-tubercular drugs. So there are fixed drug combination. For an example, artemether-lumefantrine is a fixed drug combination which has to be given in order to prevent resistance to the monotherapy. So it has to be followed. Unethical promotion of the drugs by the pharma industry has never to be allowed, and there are many a times unethical combination like ORS and zinc, like lactobacillus or probiotics with antibiotic are never to be promoted. So the clinical pharmacy, we must know there are many data analysis, clinical trials are there, then bioanalysis or microdialysis. I mean, in vitro systems. So to foster rational use of medicine, we are having a lot of trials, a lot of phase 1, phase 2, phase 3 trial. Then the molecule is being marketed in human use, and that has to be done in the market. Then post-marketing surveillance has to be done to know the adverse event following antibiotics and the drugs. So rational use of antibiotics, rational use of medicines refer to correct and proper appropriate use of medicine. Rational use requires patients receive the appropriate medicine in the proper dose for a proper adequate duration of time. If the fever goes away, that means we are not going to stop the molecule inadequately. So proper duration of time and lowest cost to them, and then community, then we can give justice to the prescription of the antibiotic. So let's doctors, first you ask what is the infection, whether it is viral or bacterial. If it is bacterial, what is the bug? Then what is the sensitive antibiotic? Then you have to think what is the duration of the antibiotic, then what is the dosage, then proper duration has to be advised. So there are multiple steps to improve rational drug use: identify the patient's problem, recognize the need for action, diagnose the disease. Without diagnosis, you are not going. Suppose you are writing your viral fever, so there is no fun in prescribing an antibiotic molecule to them. Identify underlying cause and motivating factor. Sometimes the host is bad, is a primary immune deficient, or a long-term use of immunosuppressants. So for them, you have to think least possible intervention and treatment. So step 4, start treatment by writing an accurate and complete prescription, giving proper information, instruction, warning regarding the treatment system, monitor the treatment and check the response. So if after prescribing of antibiotic 48 hours, the child is not responding, so there is every way that you must change the antibiotic, or you can add on the antibiotic. By chance you have started the antibiotic on higher because the child was sick in a NICU setup or in a PICU setup or in a HDU setup, you can de-escalate if you think the infection is caused by a low potent pathogen. So antibiotics should not be taken as antipyretics. Why I will say that many a times you see in ARI, The most common abuse is azithromycin. People start with azithromycin even with mild fever and sore throat. 99% of they are viral. They are due to respiratory viral pathogen, either by the rhinovirus or human metapneumovirus or flu or COVID or even COVID-19. Whatever may be the bug, they are viral and they are self-limiting disease. So there is no purpose of giving antibiotic to all those viral cases or common flu or uh, even common cold cases. So restriction of the antibiotic use has to be there. Otherwise, if it is used in place of antibiotic, then a time will come all the bugs will be resistant to all the common antibiotic available, and it will be difficult by 2050. The majority of the bugs they will be resistant, and we have to find out an antibiotic which is going to kill the pathogen, because the bugs and super bugs and super bugs will be available at that point of time. So to conclude, irrational use of medicines is very serious a global problem. Much is known about how to improve rational use of medicine in our clinical practice. Rational use of medicine could be greatly improved if everybody will think that where the condition the antibiotic has to be given, whether it is indicated or not, whether you are giving the same medicine to your own child, then only it will be rational use. And I urge all of you that always think and ask yourself, is it a viral infection or a bacterial infection? If it is a bacterial infection, what is the bug and what is the antibiotic of choice and how many duration has to be given? So say no to drugs and say no to antibiotics is the need of the hour. So wherever the art of medicine love, so there is also a love to humanity. So that means we have to protect ourselves so that the bugs are super intelligent. So if you are using a drug, because of the drug pressure, they bypass that mechanism. They will be surviving in the planet by a different mechanism. So that's why the drug resistant will be evolving in a day-to-day practice. So now you must be seeing that MRSA, and there are many MRSA methicillin resistant staph aureus is available, pneumococci resistant to cephalosporin, that means ceftriaxone, and pneumococci resistant to penicillin group of antibiotic. So please remember, if it is antibiotic, correct dosing has to be given and correct dispensing mechanism has to be thought of and correct method has to be given and correct duration has to be given. So that means studies suggest that the 75% of the dosing errors happen during administration of the drugs and are missed by modern electronic drug delivery systems. So that means pediatric medicine errors because of the over the count availability of the medicine. You see in India, such a populous country, 148 crore people are being present, and 25% are belonging to the 0 to 18-year population, which is catered by the pediatrician. So in them, over-the-counter medicine is available. People used to buy for every fever, which are most likely 75% of them are caused by the viruses and self-limiting diseases. But because of the usage of unethical, irrational use of antibiotic will lead to a bad days, which is supposed to come in the coming era. So how we, doctors, the caregivers, the healthcare personnel, we have to take that this antimicrobial policy, that antibiotic stewardship has to be respected. The onus is with us. Now, this is the person you see, a child who is having viral fever, ARI, and starting from all these molecules which are being prescribed by periphery doctors. So this not good. So the learning message is that whatever is there, that antihistaminic, levocetirizine, at least paracetamol for the fever and normal saline nasal drop will give the better treatment rather than giving this polypharmacy to a small kid who is suffering from viral illness. So that means medication safety tips has to be told to the parents not to go to the counter and take out the molecule, and has to be given to the patients. We ask several times your patient if they understand this or not. So they should comment and they should ask their healthcare personnel. So if they are using over-the-counter medicine for the antibiotic, definitely who is at risk? It is because of the usage of the infection antibiotics. So everybody is a us. That means the parents, the patient, and the caregivers, the family person, and finally it landed up that the person who is having resistant pathogen, they are admitted into ICU. Not all the molecules, whatever is available in the planet, are not going to save this person at one point of time. So everybody of us will be at risk. So right antibiotic, right? That means war. So this I will urge each one of you, please follow antibiotic right. That means right antibiotic right. That war policy has to be adopted. Appropriate antibiotic prescribing, that is AAP, that is appropriate antibiotic prescribing, has to be followed up by in our day-to-day practice. So WHO report that antimicrobial resistance in an increasing serious threat to the global public health. Illness and hospital stays are prolonged, increased economic and social cost. The risk of death from infection is greater because of the emergence of resistant pathogen. So this antibiotic appropriate prescribing principle, that means this principle says treat appropriately, optimize, maximize, recognize, utilize, integrate the usage of antibiotic, prescribe the right way of the antibiotic in the right way, in a right duration, and for the right dispersing mechanism. So this will encourage the appropriate antibiotic prescribing if you follow that. So what are the way forward, dear doctors? That means the summary, whatever I am telling to you is that antibiotic resistance is a global problem. Much of the increase in multi-drug resistant bacteria can be attributed to the overuse of broad spectrum antibiotic. Nowadays, the Salmonella type is resistant to almost all quinolas. The drug of choice orally is cefixime and injectable is ceftriaxone. Efforts to develop new antimicrobial over the past 2 decades have lagged behind. Antibiotic appropriate antibiotic prescribing principles have direct impact on the optimal clinical outcome with fewer adverse events. So cost effective and helps to prevent the emergence of resistance is the need of the hour. So not prescribing antibiotics in common cold and flu, because it is not to be prescribed because they are self-limiting illness. So antimicrobial stewardship means antimicrobial stewardship has six corners. If you say right antibiotic to be prescribed to the right patient, right time, right dose, and right route and right duration. If you follow this, then definitely antimicrobial stewardship will be honored. Fever does not mean the usage of antibiotic. All fever are not necessarily due to bacterial infection. All fever are not due to infection. Sometimes there are non-infectious causes of fever, just like rheumatoid arthritis, SLE, and immunological causes of fever. Sometimes factitious cause of the fever. Sometimes drug fever are the causes of fever. So that means all fever doesn't quantify, doesn't qualify for the usage of antibiotic. Antibiotics are not like paracetamol or antibiotic. I have given an example. People go to the counter and take out the azithromycin as if it is the best molecule to be given to each and every fever. Before giving antibiotic, think several times what infection, is it bacterial, what bug, what dose, what route, and what duration. That I have given an importance to use or not to use antibiotic. The answer is in our hands. So that means appropriate antibiotic prescribing in children is the need of the hour. If we, all the caregivers, healthcare personnel, are real the brand ambassadors in our country, then definitely we have to keep our hands with the hands so that the usage of antibiotic can be minimized. Nevertheless, that if you are dealing with a bacterial infection, then definitely at early point of time, a proper antibiotic to be given for a proper duration of time. So you are the heroes, doctors, you are the healthcare personnel, you are the paramedicals, you are the doctors. If you have a passion to respect this antimicrobial antibiotic policy, to not to prescribe and when to prescribe in a right way, right duration, or right dose to the right patient. Definitely, the topic title that antimicrobial stewardship has to be honored, and we can save our future. We can save our generation, human generation, so that all will be loving. That because of the right usage of the antibiotic, we can save our planet from they are emergence of resistant bugs which may infect each one of us, and there will be no antibiotic to treat that. So having said that, I thank all my doctors, those who have logged in. If there are any questions, so I ask my moderator to ask me. If there are any questions, I love to answer to that. So thank you very much. And it is over to my moderator. Please take up if there are any questions are there. Then I will love to answer. So over to Ada Hapshin. Please
Okay.
take from this point. So thank you very much,
Okay.
all of you.
Okay, thank you so much, sir, for this enlightening session and explanation. With all your permission, I am taking the question from the audience one by one. So, the first question we received, sir, as antibiotic resistance continues to grow globally, what are the some of the most common mistakes you have observed in pediatric antibiotics prescribing, especially in
Yes.
outpatient
Yes.
or community settings?
Okay, so this is a very good question, practical question. I thank the doctor who has asked this question. Number one, this antibiotic threat, I mean antibiotic usage leading to the emergence of the resistant pathogen is not the local problem. It is not a state problem. It is not a country problem. I'll tell you in a globe, like in this planet, there are 220 countries are there. India is one of them. But India is one of the country which contain one fifth of the global population. So that's why India is having a big threat against this emergence of resistance because of unethical, irrational use of antibiotic. Number two part of the question, that is the pediatric age group is a threat? Yes, definitely, because in pediatric most of the infection that is caused by the viruses, they do not need usage of antibiotic. Because of irrational use, we may land up with emergence of resistant strain. So the question number third part of the question is that what are the emergence strains we are getting in our OPD basis? Number one, because of usage of antibiotic, we are getting the respiratory pathogen, particularly Haemophilus influenzae and Pneumococcus. They are resistant to penicillin and they are resistant to coamoxiclav, and sometimes they are sensitive to higher generation antibiotic. For an example, third generation cephalosporin. I'll tell you one line that this pneumococci, which is resistant to a penicillin group and ceftriaxone in the world, in the global scenario, that much of resistance we have not seen in Indian scenario. Our pneumococci is very sensitive to penicillin, and that's the reason we are using first line antibiotic, the penicillin to be given. But those cases we are having culture proven that pneumococci resistant to penicillin, they are the cases where the ceftriaxone has to be used. But if the pneumococci are resistant to pneumococci, I mean ceftriaxone, then the molecule will come in the pipeline as a linezolid. The pneumococci resistant to penicillin, I mean ceftriaxone, the linezolid will come to the treatment policy. Coming to second bug, that is MRSA. That means community acquired MRSA, that means methicillin resistant Staphylococcus aureus, and they usually sensitive to ticoplanin, or sometimes we are using clindamycin to reduce the toxin production. Then comes, there are multiple organisms nowadays are resistant. Number one is E. coli, number two is Shigella, number three is Pseudomonas, number four is Klebsiella, Enterococci, and there are many other organisms which are coming out in a bigger way. And nevertheless, there are some resistant Salmonella typhi causing enteric fever we are coming across in our day-to-day practice, and which are community-driven drugs. But having said that, those bugs which are present in the ICU or present in the hospital, they are known as hospital-acquired infection. They are more notorious than the community-acquired infection, because community acquired infection, they are very sensitive to the second tier or third tier antibiotic. But whereas the hospital acquired infection, because of the emergence of the resistance, so they are not sensitive to the common antibiotic, and we have to go upscale with the other antibiotic which can kill the bugs. So this is about your answer to the question which you asked to me.
Okay. Thank you so much for the answer, sir. I hope you did justice with the answer, sir. So the next question I'm taking, sir, the question is, what role do parents play in antimicrobial stewardship?
Yes, this antimicrobial stewardship is the hospital-based program. So, in a hospital, what we have done, I am working in a medical college in Odisha. What we are using, if the patient comes, for an example, neonatal sepsis, we have a protocol, we have a design, we have a method, we have a guideline in our hospital that whoever comes, the first line antibiotic will be cefotaxime and amikacin. If the child doesn't respond within 48 hours, or if the culture report or the bacterial system says about a resistant bug, then we can go for the second line antibiotic like piperacillin and tazobactam. So likewise, the first line cases, those who are admitted with pneumonia beyond 3 month age group, first antibiotic is IV ceftriaxone. If it is not responding, we can upscale with the second tier of antibiotic, that is piperacillin, or we can add to vancomycin if it is a bad host. So similarly, there is a usage of antibiotic policy in our hospital. So I urge in all hospitals across the country, the individual available bug and resistant pattern, according to that, the antibiotic stewardship program is going on in each and every hospital. Suppose I'll go to AIMS New Delhi, the pattern of antibiotic stewardship differs from in my hospital and is not same in Bangalore or in Mumbai or in any other corporate hospital. The hospital differs. Likewise, the organism causing the disease also differ. The pattern of antibiotic sensitivity also differs. So that's the need of the hour. So we have to know that the local availability of the drugs and local sensitivity pattern has to be followed in our hospital, and that we are following. So I urge the doctors who are present here, you have to look your local availability of bugs and what are the antibiotics are there to kill your local available pathogen. That has to be followed. So it is not same that one shoe for all. So it is not one antibiotic for all pan India. It is not true. So many a times there are guidelines, there are policies are there, but that is meant for a universal use. But that can be changed as per your bugs, as per your infection and the sensitivity pattern.
Okay. Thank you so much for the answer, sir. So the next question is, how can healthcare professionals better educate families about the dangers of overusing antibiotics?
Yes, it is the behavior. Suppose healthcare professional like me and everybody, so they are healthcare professional like me. It include doctors, it include paramedical nurses, it include pharmacists, it include all the persons who are designed to deliver the care to the patient. So that means healthcare. The major junk or major population of that is doctors. So we deliver antibiotic, we deliver the drugs. Our message is carried by the nursing population. So what I see, there must be a policy. We must not overuse. Nowadays, I will tell there are two faults are there. Number one, nowadays patient themselves, without consulting the doctor, they go to the shop, they bring out one antibiotic and start by themselves, which is not true. Why it is happening? Because over the counter the medicine is prescribed and the shopkeeper gives for one bottle, you take and give for 3 days, and after 3 days the fever goes. People think that this antibiotic works and they repeat that type of treatment in the second and third episode of fever as well. So there is a policy has to be there that no shopkeeper should sell any antibiotic without the doctor's prescription. So that has to be made a policy so that the misuse of antibiotic will not be there. There are many places now you go to outside India in the Western world, you cannot purchase any antibiotic or molecule from a shop without doctor's prescription. So that has to be followed in our country as well. Then only we can say that the antibiotic misuse will not be there. Number two, in a hospitalized patient, it is not me or anybody that whoever comes, suppose I am senior, it is my that I am having a Hitlerism. I can use any antibiotic I want, and this antibiotic because of the pressure of the pharma industry. Now, pharma industry people will come, they will say this is the costly antibiotic and this will kill all the pathogens. So, no need to do testing, and you use then left and right this molecule for each and every cases. That's not true. We should not be biased by the pressure given by the pharma industry people. That is second. And third, we must ask ourselves, we must change our behavior. Is it a viral infection or a bacteria? If it is viral, no use of antibiotic. You can wait and watch for 48 hours. Suppose I'll tell you, now in front of me, moderator Afshin is sitting. Now you will be having some running nose and fever and headache for 1 or 2 days. So I'll tell you just go and take Senalius tablet, one tablet twice a day for 2 to 3 days, and wait and watch and call me after 3 days. After 3 days, you will be much better and you don't have anything else other than little bit weakness. Then I'll tell you, you take good amount of water, hydrate yourself, go for good amount of ORS, fruits and juices you take. After 7 days, you are okay. So there is no need of antibiotic. If I start from day one, azithromycin 500, take once a day for 3 days, then I am not a good doctor. I am not a good healthcare personnel. So it is, if I am not taking, why should I prescribe that molecule to you? I mean, my client or my patient. So the behavior has to be changed. Then only we can give justice. Whatever we say here in a debate or in a class has to be percolated in our community practice. Then only we can say that this type of antibiotic stewardship will have a goal in the long run so that we can help ourselves. So the bugs, they are fighting for their existence. We the human, we are fighting for our existence. So there must be a harmony, and you must be knowing it is a world planet of more than 50 more than millions of years ago the bacteria they existing, and they will exist after us also. So that's why they will be there, will be there, but is a harmony will be there, so that we should not give left and right use of antibiotic unnecessarily. Unnecessary use of antibiotic in a condition where it is not indicated, if we follow that much only, then healthcare personnel will be the good one, and we can respect and we can honor the antibiotic stewardship program, and our patient will be very much they will follow our advice. And if you give unnecessary antibiotic, number one, that will cause bad taste to the tongue. Number two, many of the antibiotics they land up with diarrhea, and many of the antibiotics they decline the immunity. All those things indirectly are happening to the patient because of irrational use of antibiotic. So I suggest no healthcare personnel should write unnecessary use of antibiotic. If this is being followed, the cost of therapy, the cost of treatment will go down. Now, if you take any child to a nursing home or any child to a private hospital, they start with higher tier of antibiotic. Then the bill will be 50,000 or 1 lakh rupees for one pneumonia, but which is not required. If you start with basic antibiotic, if at all it is bacterial pneumonia, with a span of 5 to 10,000 rupees, your child will be okay. So that means misuse of antibiotics should not be there.
Thank you so much for the brief answer, sir. I hope it will help him. So, with this, sir, we come to the end of today's insightful session, sir. On behalf of MedTalks and IGCP Group, I would like to extend my heartfelt thanks to our esteemed speaker for sharing their valuable knowledge and practical perspectives with us today, sir. And a special thanks as well to all our participants for joining and making this session meaningful. We hope you found this discussion informative and thought provoking. Stay connected with MedTalks for more such academic sessions and knowledge sharing programs. Thank you once again and wish you all wonderful day ahead, sir. Thank you.
So thank you, Option, for from IJCP, nicely moderated. I must thank to all my doctors, those who have logged in and have spectacular, showcased your program in the IJCP platform. So I thank all my viewers, and I hope this type of message giving and knowledge giving platform will be going on. And I am a regular speaker in your platform and planet as well. And I hope many more topics I'll be talking and discussing in your platform in future. So I hope all the best to you and our doctors, those who have logged in. Thank you very much. Namaskar.
Thank you, sir.